Podiatry plays a crucial role in maintaining foot health, preventing complications from chronic conditions, managing pain, and supporting mobility. Step by step, understanding foot and ankle health. Tonight, On Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by...
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions: Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health.
Good evening and welcome to On Call with the Prairie Doc. I'm Dr. Jill Kruse, your volunteer Prairie Doc for this evening's program. Tonight, we are discussing foot and ankle health and answering your questions throughout the show. Podiatry plays a crucial role in overall health and well-being as it focuses on the prevention, diagnosis, and treatment of conditions affecting the feet, ankles, and lower extremities. The feet serve as the foundation of our body, supporting us with every step we take, and any issue in this area can have far-reaching implications for mobility and overall quality of life. In the studio this evening are Dr. Nephi Jones and Dr. Ryan Prusa, both practicing at Avera Orthopedics, Brookings. Thank you both for being here with us tonight. Dr. Jones, could you share a little bit about your background and what brought you to this field?
Yes. I originally grew up in southwest Iowa. I worked as a paramedic and a police officer, and then I went back to school, got a degree in biology and in investigations. Went to school in Chicago at Rosalind Franklin University of Medicine and Science. Graduated there with my doctorate in podiatric medicine. Went to residency in Des Moines, ended up here in Brookings. I wanted to find a specialty where I could take care of people but also do surgery, which I really enjoy. And I found podiatry was my niche. And
excellent. Well, Dr. Prusa, I'd love to hear a little bit about your journey as well and what brought you to Brookings.
Yeah, absolutely. So I'm actually from Iowa as well, just like Dr. Jones. I did my undergraduate in Des Moines at Grandview University. After that, I went to Des Moines University in Des Moines, and then I also did residency in Des Moines. So a lot of Iowa and a lot of Des Moines in there. I actually did residency with Dr. Jones before coming up here. And what got me into podiatry is I love working with my hands, and I think it's a really important field that we can keep people moving and pain-free, and that's very important in their lives.
Excellent. Well, I also went to Des Moines University,
Yes.
so we all have the Des Moines connection here.
Absolutely.
Great. All right. Well, before tonight's questions, I'd like to take a moment to express my gratitude to all our viewers. As a volunteer Prairie Doc, your contributions each week are invaluable. Every dollar you give helps us produce meaningful content that empowers individuals to make informed health decisions. Now let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on podiatry. There are 3 ways to reach us. Call us at 1-888-376-6225, send an email to ask@prairiedoc.org, or engage with us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous and no information will be saved. If you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. However, it is not a requirement to submit a question. We'll announce the winner at the end of this program. Well, we already have 11 questions from viewers that have emailed or sent things on Facebook. So I know this is a very important topic. So we're going to just dive right in. So the first viewer says that they are a 52-year-old female and lately have been having some foot pain on the top left of her left foot. The pain happens when she stretches it, especially in the morning, or rotates it in a circular motion. It doesn't hurt to walk or run, and some days it feels worse, other days it feels better. What could this be, and any suggestions?
Wow. It's hard to tell without like physical exam and looking at it, but it sounds like it could be related to either the small muscle bellies on top of the foot that come from an area called the sinus tarsi, or midfoot arthritis. When we think about stretching, there's an area on the top lateral side of the foot where we have these small muscle bellies that run out to our toes. And if we're stretching those and they're too tight or they're inflamed, that can cause discomfort. Rotation, that area moves when we rotate and can cause some impingement. Or your midfoot joints, sometimes when you do rotation through there, if there's arthritis starting through there, or maybe even the subtalar joint, maybe they have like a mild flat foot or something that they don't know, and that causes some impingement syndrome, inflammation. So I think that's a good place to start.
Yeah, I agree. I think that physical exam will really help kind of basically narrow down exactly where that pain is coming from. I think that's really important in this case. A little unusual that it doesn't hurt when she walks or runs. So that definitely is an important piece of information.
Towards soft tissue, that's instead of structural, biomechanical.
Yep. So possibly tendonitis, could be a ligament issue. But again, I think that physical exam where we can see that patient in clinic and really kind of narrow down exactly what's going on, and give us the ability to look at other testing that could also help with that.
All right. Well, the next viewer says that they're a runner, and for a while now, sometimes their heel hurts after they run. What can they do about the pain? It comes and goes. They wear good shoes. Is there anything they should be doing or concerned about here?
Now, it depends on if it's the bottom of the heel or the back of the heel. So you got two main structures there. You have your Achilles tendon on the back. You have your plantar fascia band on the bottom. It's very common to develop plantar fasciitis, heel pain on the bottom of the heel. Usually it's due to a tight Achilles tendon, so very aggressive stretching, different things you can look up online, you can YouTube for plantar fasciitis or even Achilles tendon stretching. So it's probably an overuse thing and not enough stretching beforehand, warming up to get those ligaments warmed up before you really run and you get that shock, constant shock on them.
Yeah, I was going to say a very similar thing. Without knowing whether it's coming from the back of the heel or the bottom of the heel, kind of the common denominator that's an early conservative treatment method for either plantar fasciitis or Achilles tendonitis is calf stretching. So I think that trying some calf stretching, see if they can get that stretched out and that pain to go away, and if not, then can always...
Could be shoe gear as well. It could be, if it's on the back and it's rubbing on the heel, that's one thing to look at.
Okay. All right. Well, another viewer says they tend to get a lot of ingrown toenails. Is there something they could do to prevent them? They're painful, and sometimes they have to go to the doctor for treatment.
Yeah, so yeah, for sure. So with ingrown toenails, basically just kind of an increased curvature of the nail along the border. And then when it presses into the skin, it becomes very painful. Sometimes that nail will press into the skin hard enough that it creates a little opening in the skin, which can cause an infection. Typical ways to prevent that, one thing people can do is try trimming the nail straight across, where that sharp edge of the nail doesn't get embedded into the skin quite as much. It sounds like this person's had kind of recurring issues on and off where they've had to see a doctor and have probably been on some antibiotics, where we might talk about a nail avulsion procedure. So that's a more permanent option for someone who's been suffering with ingrown toenails for a long time.
All right. Well, I'm going to keep going because the questions keep. We're up to 20 questions already.
Oh, wow.
Yes. Wow. Another viewer says their father was diagnosed with neuropathy in his feet. His pain seems to come and go, but we have not found a solution. He sees lots of commercials and wants to try one of the clinics that promises relief. Do they actually work? His doctor said there's no cure for neuropathy, but the clinic promises to cure it.
Yeah, that's a tough question. Neuropathy, is very, very tricky to treat. And they're right; it's incurable if it is neuropathy. I think the big thing to start with is diagnosing what type of neuropathy. Is it from diabetes? Is it a radiculopathy that's similar to like peripheral neuropathy, like we think? Is it a pinched nerve in the back causing the symptoms? Those can be treated. This new red light therapy that's out on the market, there's not a lot of scientific evidence that shows that it works, but there is a lot of evidence that shows that we cannot reverse the effects of damaged nerves yet. And so anytime somebody comes into clinic, sees me and complains of neuropathy symptoms, nerve pain, the best thing to do is start with nerve studies. Find out what type of neuropathy is it. Look into their history. Do they have diabetes? Have they had chemotherapy treatment? Are they on something that can cause neuropathy? Is there something we can reverse? So trying to figure out the cause of neuropathy is a big key to that, to be able to treat it. And then kind of like they alluded to, like there aren't a lot of good treatment options. It's more symptom control at that point.
All right, so a viewer did ask, was there any support with that red light therapy? So.
Not yet. There's not a lot of scientific articles out there that show that it is effective now. I'm hopeful that people who are using it can do research on it, and if it is proven to work, then we can get insurance to pay for it. That's another thing, is if there's not a lot of evidence that shows that treatment works, insurance is reluctant to pay for it, and it can get very costly. And so that's a reason we need a lot of medical research out there. So we can get things paid for that work.
All right, another viewer said they were recently diagnosed with diabetes, and the doctor mentioned that they need to be more aware of their feet in general. Why is that? They don't have any problems now. Why do they need to care about their feet?
Yes, so very good question. Speaking of neuropathy, one of the most common complications of diabetes in the foot is actually peripheral neuropathy. And the result of that is that the person is not able to feel the feet as well as a normal person would be able to. So the concern is that if there is a callus that becomes too thick, it could develop into a wound, which could lead to infection. So where the doctor is saying be aware of your feet, what I typically recommend is just daily foot checks. So just a quick glance at the top and the bottom of the feet. Just make sure that there's nothing there that could be concerning. And we're essentially trying to catch those problems early so that we can treat them and they don't become a bigger complication for that patient.
So sit down when you're doing it. Don't be checking in the shower, standing on one foot.
No, yeah. Yes.
All right. So
Safely
check your foot. Look at the bottom, look at the top, between the toes, make sure there's no sores.
Yep. Yes. And for the people that have difficulty looking at the bottoms of their feet, they can always have someone check for them, or like a hand mirror placed at an angle up against a wall is also a good option where they can just take a quick glance.
All right. There we go. Excellent. Well, another viewer says they have several calluses on their big toe, and usually they don't bother them, but lately it's been hurting when they walk long distances. What can be done for these big calluses?
It depends on kind of why they're developing in the first place. Is it shoe gear problem, or is it a biomechanical issue? Do they have arthritis in their big toe joint that is preventing their toe from moving appropriately, so then you get that extra friction? Using over-the-counter pumice stones and non-medicated pads just to alleviate the pressure and symptoms. If they're getting larger and they're more painful, they should probably come in and get them checked to make sure it isn't a sign of something bigger, like, hey, you have really bad arthritis that could be addressed or early arthritis that can be addressed to prevent it from worsening. So a lot of times you start to develop these calluses and you can get wounds underneath them. And so then you see the callus is starting to look bruised, it's hurting more often. And that can be an early sign that there's a deeper problem going. And so I always recommend, if you're developing calluses, you don't know why, they're painful, come see us.
All right. Well, another viewer says their mother has a bunion on her left foot and it has begun to bother her. Is there anything they can do at home to help keep her mobile without having pain?
Great question. Yeah, so we do see a lot of bunions in our practice. Some of the things, I know the viewer asked, what can they do at home? Some of the conservative or non-surgical options are making sure that the shoes that the person is wearing has adequate space to accommodate that bunion deformity. There are a number of other like pads and cushions where we can try to remove some of that pressure and relieve the pain. Other than that, there's always surgical options, which we're happy to discuss with people if those conservative things are not effective for people.
All right. Well, next viewer said they read my essay where I was talking about arches in the feet, and they state that they have flat feet and can't seem to find any shoes that help them, and their feet hurt after they walk all day. Do you have any recommendations for flat feet, low arches?
I would say it's good to start with a good pair of shoes, but then if those are ineffective, most shoes aren't designed to have arch supports, or even the insoles that come in them are too soft, they're not rigid. So adding in a rigid arch support like a power step or some other orthotic device to help prevent that collapse and bring that arch up. So most shoes are pretty rigid, they're pretty supportive, and so if you can find a pair that are comfortable but you just need the added support, then you need to find an over-the-counter orthotic to put in there to help keep that arch up.
All right. And there's a range of orthotics, right? From the Dr. Scholl's to the more expensive, Power Step, Spencos, to custom. How does someone know where on that spectrum they need to be? Because it could be $15 to $500.
Yes. A $30, I think Power Steps they're fairly inexpensive. The device should be rigid, so if you set it on the table and you find the arch and you push on it, it shouldn't collapse down. Where some of the Dr. Scholl's are more cushiony or gel, they don't have that support system. So if we're looking for arch support to prevent collapse, the device needs to have support, and so that's one thing to look at. Now, if we're needing a lot more control, a lot more customization, then we look at getting custom orthotics, but I always have people try over-the-counter first, because if that works, that's the cheapest option, where you could buy custom orthotics and they don't work and now you're out all that money. So it's easiest to start with over-the-counter products. We can always modify them and things, and then after that move on to custom if we need them.
Okay, so support is more important than cushy.
Yes. Yep. That's I think the biggest misconception with insoles or arch supports, whatever you want to call them, is people think, oh, my feet hurt, I need more cushion, I need more gel. No, you need more structure support. If we get that structure support, that'll do you more good in the long run.
All right, well, hyperbaric oxygen therapy involves breathing pure oxygen at elevated pressure to improve oxygenation and support the body's healing. Katie Jones, a certified nurse practitioner with Brookings Health System, explains more about this therapy.
The hyperbaric chamber is a device, a machine like such, that allows an individual to breathe in 100% oxygen in a pressurized environment, so pressure that's above atmospheric pressure. And when you are breathing in 100% pure oxygen in that pressurized environment, the oxygen in your blood dissolves easier and then is transported throughout the body a little bit more readily. So by doing that, it can decrease inflammation to any sort of damaged tissue or organs.
Jones says individuals use this therapy for wounds located on legs and feet.
So we see in a lot of individuals with wounds on their feet, whether it's related to diabetes, neuropathy, meaning decreased sensation in the feet, trauma, such as stepping on something or having a surgery, those types of things. So we do see it quite often.
All right, my dear, all set? Here we go.
Patients going through the therapy can expect typically 30 to 60 treatment sessions. It goes hand in hand with other treatments.
And that is in conjunction with regular wound care, typically some antibiotic treatment, whether we're working with infectious disease or podiatry or whatever that might look like. But 30 to 60 treatments typically. And we are reassessing these individuals usually on a weekly basis at wound care to decide, do we need to continue these or not?
Each treatment duration varies based on the required pressure levels.
And that depends on what depth they're going to with their treatment. So at what pressure they are at. The higher the pressure, the longer the treatment. And so that will depend on that. But by the time they check in here and they leave here, it's anywhere from about 2.5 to 3 hours, just depending on what that treatment looks like.
Welcome to the surface. You made it.
Well, what conditions besides foot issues have you used hyperbaric oxygen therapy with?
Mostly like osteomyelitis or bone infection, venous leg wounds that are very difficult to heal through just traditional wound care. But peripheral arterial disease, especially after a patient has a revascularization, we're trying to preserve tissue, we're trying to preserve the limb, we'll do hyperbaric oxygen therapy.
All right. Well, have you seen some pretty amazing results with the hyperbaric oxygen?
Yeah, absolutely. Another use case for hyperbaric oxygen is crush injuries. So when you have a traumatic injury where there's significant damage to that tissue due to that crush, that can really bring those tissues back and save a lot of the possible tissue that we can.
Excellent. Well, we'll get back to questions here because they just keep coming. So another viewer says after they had an x-ray and then an MRI, they were diagnosed with Morton's neuroma. Other than using a support pad in their shoe, what treatments or steps can be taken to manage? They would like to avoid surgery. So first, what's a Morton's neuroma?
Morton's neuroma is classified as a digital nerve irritation or enlargement, where the nerve that runs through the bottom of your foot out to your toes gets inflamed or bulbous, it gets enlarged, and it causes constant pain, especially with weight bearing and certain activities. So how do we treat that? We typically do what's called a metatarsal pad that we put on the sole of the shoe or the foot to kind of separate the bones, take the pressure off that nerve. We also use steroids. We can inject those steroids. They used to use sclerosing injections to try to shrink down that nerve as well. And then when those things don't work, we talk about surgery.
Yeah, and I think for interspace neuromas or Morton's neuromas, it is definitely important to go through all those conservative treatments because the surgery for a Morton's neuroma is a neurectomy. So that's where we're actually removing that nerve, which does alleviate the pain, but it also comes with permanent numbness to the tissue in the skin that nerve supplies. So yeah, we definitely try all those things Dr. Jones discussed.
Yes, and there's a high rate of recurrence with neuromas when you excise them as well. We call it a stump neuroma. So where we cut that nerve, that end of that nerve can engorge again, and then we have that constant pain again. And so we really try to avoid surgery as well. The patient doesn't want surgery, we don't want to do surgery, so we try as many things as we can to try to relieve the symptoms.
All right. Well, another viewer says they love running, but they're afraid they're going to ruin their knees and ankles. What can they do to extend their running life?
I would say you have to look at shoe gear and maybe some insoles that provide shock absorption. So the big thing with running on surfaces like concrete and those hard surfaces is the shock absorption through your joints. And so if we're trying to preserve those, then looking at the type of shoes we're wearing, how much shock absorption goes through the shoes and as opposed to our joints, the surfaces you're running on, if you're running on softer dirt trails as opposed to concrete can kind of help, but then you're more likely to get an injury. So it's a give and take kind of thing, depending on how many miles they're running a day. If they're doing 5 miles a week, they're probably less likely to be damaging their joints as opposed to if they're doing 8 miles a day, then they're a little higher risk for that. And so I would start with shoe gear and then the running surfaces. You can do elliptical, indoor things with low impact that can help the joints as well.
Yeah, I was going to say mixing in those not as high impact activities is important. So swimming, elliptical, bike, things like that can not have quite as high of an impact on the cartilage surface. And then also just being aware of how your gait is and how those biomechanics are working, so that we're not putting all those high stresses on those joints.
All right. Well, another viewer says their son plays hockey and constantly gets athlete's foot. How can we keep this from happening all the time?
Yeah, so athlete's foot is another thing we commonly see in the clinic. It sounds like they've probably tried some over-the-counter antifungals, which are good. You do need to apply those to the skin to treat the fungus. The other side of it is treating the person's shoe gear. So in this case, those hockey skates. You need to get an antifungal powder or spray that can go down inside the skate and actually kill that fungus within the skate too. Or else you'll just be reinfecting the foot every time the skates are worn. Another thing you can do is ensure that the shoe gear is dry between uses. So that can be with a boot dryer, or sometimes it's just ensuring there's enough time in between uses that it can completely dry, which is not a very good environment for that fungus.
All right. Another viewer states that she has had flat feet all her life and has severe pain on the outsides, the lateral sides of both ankles. What could be causing that pain?
So that's what we talk about, end-stage flat foot deformity, where we start to get that outside or lateral foot impingement pain. As the foot collapses at early stages, it's kind of like on the inside on the arches. As it continues to worsen, we get that foot really collapses, then we get that impingement syndrome on the outside of the ankle and foot area. So it sounds like end-stage flat foot problem. Inserts, shoe gear, it depends on if it's rigid. So we start talking about, how much does the foot move? Is it locked into a flat position, or can we still move it? Are there surgeries we can look at doing, shoe gear modifications, those type of things? But as the flat foot deformity worsens, our symptoms kind of move from the inside to the outside, and then eventually it's just painful all the time.
All right. Well, another viewer says they had pain in their foot, similar to about a year ago, so it's been going on for a while. They said maybe gout, but uric acid was normal. It's on the outside of the foot, radiating up to the top and in the ankle. Pain and burning.
So that could be a number of things. It certainly could be related to gout. The most common joint to get a gout flare is actually in the big toe joint. So a little bit unusual that it's on the outside of the foot and kind of in the ankle area, but it could happen. Gout is a condition where you have elevated uric acid in your bloodstream and you're not able to get rid of that. So the test for that is we draw your blood and see what that uric acid level is. The downside to that is if you're having an acute gout flare, that level can actually be lowered because that uric acid is crystallizing in the area of the attack. So it's not always the most reliable test to tell if someone has gout, especially if it's drawn during the time that it's painful. So, but again, I think a good physical exam could really help kind of isolate where that problem is, and there certainly are a number of other things that could be going on.
All right. Well, another viewer is asking about gout. Says, my husband continues to get gout all of the time. What can he do to prevent this from happening over and over?
So, when we have chronic gout flares, the symptoms aren't going away, or we're just having a gout flare, we take some medication, it gets better with gout flare. And we get caught in that cycle. It's actually a gout clinic down in Sioux Falls through Avera, through the rheumatology department, that will send people to have a deeper dive into why are they having these gout flares. Usually the medications we give help you excrete that uric acid to lower the gout attacks, but if those medications aren't working, there's other medications to give to tell your body to stop producing uric acid. If they've developed the crystals, Dr. Prusa talked about developing crystals, the soft tissue turns into this mass of what we call tophi, where it's just this ball of crystals. There's medications to actually tell the body to resorb that or get rid of that. And so typically when it gets to be this bad, we're having these chronic flares, we get you set up with the gout clinic in Sioux Falls.
Yep. And I think a big takeaway is that it's not normal to continue to have gout flares when it's managed correctly. So I think seeking more medical advice would be a good idea on that one.
All right. Don't just tough it out.
Correct. Yep, do not. Yeah.
All right. Another viewer says, what causes pigeon toe? And if I don't get surgery, will it get worse?
So, pigeon toe, hallux varus, the big toes come in, which is opposite from a bunion where the big toes go towards the other toes. So pigeon toe, usually it's genetic. Usually we see it in children. One quick, easy way to try to fix it when you see it in adolescents or kids before the age of walking, less than a year, you put the shoes on the wrong feet to help to correct those, get those big toes out. And so the question becomes, if this developed later on in life, was there some sort of injury behind the scene where we injured those collateral ligaments to now your toes are drifting into that position? Because usually it's genetic. Usually it's a young child, infant issue that we can correct early. And so if it's happening later on in life, it's usually traumatic. Something has happened where those ligaments are loose or ruptured, causing the toe to drift inward.
All right. Well, another viewer says, I think I may have a plantar's wart starting on the bottom of my foot. Do I see a podiatrist or a dermatologist? Who do I go to treat that?
Either one.
I think either option is viable. As far as treatments that we can perform in clinic, we do have options where we have different topicals that we can use, whether that's cryosurgery and freezing that lesion, or other medications that can be applied to try to treat that wart. But podiatry certainly is a good place to start. Most dermatologists are kind of scheduling out pretty far, typically. So if you want to be seen a little sooner, probably start with a podiatrist. But dermatology can certainly play a role in that, and can contribute to that treatment too.
I'd like to add to that a little bit. I don't know how many times I've seen people come in thinking it's a wart and it's something else.
Yeah.
And they've been trying to treat it with over-the-counter wart removers, and they're just kind of creating a bigger problem. And so I think it's important to come see us, get it diagnosed as either a wart or some other type of lesion before we start treating it with over-the-counter things.
Make sure you know what you're up against.
Yes.
Very important.
All right. Another viewer says, do your feet get flatter as you age? My arches seem to be getting smaller now that I'm in my 80s.
I would say absolutely. You get a lot of patients that say that their feet are getting bigger as they get older. They're wearing bigger shoes than they used to be. I think a lot of that comes from the collapse of the arch. As the arch collapses, we see kind of that elongation. Your foot's not growing, but it's perceived that your foot is getting bigger. And so, yeah, our ligaments and joints and things, they wear out as we get older, and so that causes that collapse. And so, absolutely, it can happen.
Also with pregnancy, I noticed.
Yes.
Everything got lax, ligaments got lax, feet got a little bit
Yes.
flatter at that time,
Yes.
shoes
Your
sound a little bit
shoes,
tighter.
Yeah.
So definitely can affect all of that thing. So, right. Well, minimally invasive foot surgery involves correcting foot conditions through small incisions, often with little to no hardware required. Podiatrist Dr. Trevor Haynes, owner of Elite Foot and Ankle in Oregon, spoke with Prairie Doc about this procedure and the benefits for patients.
So it's really taking back the big incisions, the big plates, the big screws, that kind of stuff.
Dr. Haynes says the minimally invasive foot surgery is usually done on patients with bunions, hammer toes, and arthritis. The procedure is done with local anesthesia.
The great thing about minimally invasive is I do a lot of my surgeries just here in my office. I have a surgical suite, and so I just use local. I'll numb them up, and I can do a bunion, I can do hammer toes, I can do all those without the added risk of anesthesia.
He says that minimally invasive foot surgery may be appropriate for a wide range of patients.
I can do surgery on patients that are on blood thinners because I'm using small incisions. I can do 80, 90-year-olds because it's, again, minimally invasive. So there's really not a horrible candidate for minimally invasive.
Patients can bear weight and walk after the procedure. The healing process is supported by a specific bandaging technique which allows patients the ability to walk.
I walk all my patients right away. Even with a bunion that I don't use plates and screws on, they're walking in a boot day one.
Dr. Haynes recommends orthotics after having a foot surgery done.
But I will recommend good shoes. Definitely don't recommend, after you've had surgery, you've put the effort into fixing your foot, go back to this cheap shoe, cheap built shoe, because that's just going to lead to more problems.
Well, it was nice to hear from Dr. Haynes again. He used to be here several years ago and then moved away, so nice to keep track of what he's been up to. So, well, let's get into more questions because they are just coming. Another patient says her daughter has turf toe. What treatments are available and recommended? Again, what's turf toe? How do you get it?
Yeah, so turf toe is an injury that occurs when there's hyperextension of the big toe. So essentially, those structures on the bottom of the big toe get stretched and sometimes can even be torn. There are also a few bones that are free floating underneath that big toe joint that can occasionally fracture or get other damage to them. So initial treatment for turf toe is simply a mobilization. So getting that toe into a nice straight position so that it doesn't flex up essentially, so that those structures can heal. Long term, there can be other issues with that, and if people fail those conservative treatments, then imaging is sometimes warranted with MRI, so we can evaluate all those structures.
Okay, so is there like a brace or a splint, or how do you keep a toe from not moving?
Yeah, so usually it's done through like a rigid plate. So whether that's done with a post-operative shoe that is just rigid, so there's no flex at all of that big toe, or occasionally we'll use a device called a Morton's extension, which is a carbon fiber plate that can be worn in a regular shoe that prevents movement of that big toe.
Okay. Another viewer said that the skin on their feet peel all the time. What could be causing this, and what can they do about it? They use lotion every day, doesn't help.
It could be a fungal. You definitely see a lot of athletes' foot where we get this dry, peeling skin all the time. It could be their skin absorbs that lotion and then it dries out, and they need to try like a petroleum-based, like Vaseline or a bag balm lotion to really hydrate and penetrate those layers to keep them from peeling off so rapidly. But you think about fungus a lot when you heal that. Just a lot of dry, scaly, peeling skin could be a fungus issue, and so trying an over-the-counter antifungal and see how that responds.
All right, so it's not always itchy, burning. It could just be peeling.
Could just be peeling.
All right. Another viewer says they broke their foot 5 years ago, but still having pain sometimes in the area where it broke. Will this ever go away, and why does it happen? It's worse when it's cold.
Oof.
Yeah, so I think probably a good starting point would be to get some x-rays because you want to make sure that that fracture healed and healed correctly. The other major thing that we see after a fracture is post-traumatic arthritis. So if that fracture happened to go through a joint, that also causes damage to that cartilage surface of the joint, which can then turn into arthritis. And a lot of times those pressure changes with cold can certainly make that pain worse.
All right. Well, another viewer says they have plantar fasciitis and had been wearing shoes all the time. It's helping. However, when they don't wear their shoes, even in the house, their feet start to hurt again. Will this always happen? Will it eventually go away? What can you do to help?
Plantar fasciitis, it strikes everyone. it is a tough one to treat sometimes, especially when it becomes very chronic. It will go away eventually on its own. The ones that are more persistent means we need to focus on it more intently. Doing just the simple shoes and stretching may not be enough. Sometimes you need medication or injections, sometimes formal physical therapy. You can do like massage therapy, imaging to make sure that they don't have a heel spur that's fractured that's causing their issues. So it will go away eventually at some point is what I was taught in residency, but sometimes it could be a year, it could be 2 years that we just don't know. So that's why you should treat it and not just deal with it.
All right. So another viewer said they tore their Achilles tendon and have surgery scheduled. What's the recovery like for this? And what do they do during the surgery?
Well, that's you can fix Achilles tendon several different ways. So and then the postoperative recovery can be based on how you fix it. If are you doing minimally invasive, like we saw Dr. Haynes talk about, where you make small incisions, repair the Achilles tendon? Are you opening it up and doing end-to-end repair? Are you using anchor system into the heel? And then that kind of drives the postoperative recovery. If we can do minimally invasive and we're anchoring it, can we get you active sooner, get you walking sooner? Physical therapy is always a big part of the postoperative recovery as well. Usually I prefer to start after the incisions are all healed. Once the incisions are healed, we can start non-weight bearing therapy, start activating those muscle groups. Weight bearing, it can be 6 weeks, it can be 12 weeks, it can be 2 weeks, it depends. We see a lot of athletes that they fix them and they get them moving right away. So activity level, that kind of plays a part in how you fix it.
Yeah, and I would say a typical expectation would be probably 4 to 6 weeks of non-weight bearing while that tendon is healing. And during that time, the foot is typically immobilized in a splint or a boot to keep everything nice and stable where it needs to be so that tendon can heal.
All right. Well, another viewer said they sprained their ankle. No pain now, but it still swells every night. No fractures. What do they do? Why is it still swelling?
Good question.
Well, so we think about sprains. You tear a ligament. Sometimes they can persist longer than if they just fractured the bone, and the bone can heal. Sprains can persist for months to years. They're active all day long. They sit down. That ligament's trying to heal itself. You've been active on it all day, so then you get that inflammation, you get that swelling. It may not hurt, but the body's still trying to repair and remodel these structures to make it stable. So post-op, or not post-operative, but post-traumatic swelling can persist for a year or more after injuries.
Okay, so if this happened at Thanksgiving, don't be concerned that there's still swelling.
Yeah, the big thing is pain-free and stability. It doesn't feel unstable.
All right. Well, another viewer says they have radiculopathy and hammer toes, and their biggest problem is balance. Any ideas? They would like to avoid surgery, but how can you help with that proprioception and that balance?
Yeah, I think that's where we would really utilize our friends in the physical therapy department, because there are a lot of different exercises and treatment modalities that they have to really assist in kind of gaining that balance back. Of course, if the hammer toes are painful or bothersome, those can be addressed by a podiatrist. We have conservative and surgical treatments. But as far as balance goes, and even radiculopathy, physical therapy can definitely be helpful.
All right, I know they've got a really cool balance board system, a little fancier than my Wii at home, where it can kind of tell how, is the pressure on the front of the foot or on the heels, and if you're too far on the back of your heels, you could fall backwards easier, and getting just that right center of gravity.
Yes. Yep.
All right. Well, another viewer says they have very bad pain in their feet, just sitting or sleeping, no problems with walking, just when stationary they get this sharp pain when they're not moving.
Ooh, that could be a lot. That could be a number of things. Go back to the physical exam. Do they have good pulses? Do they have underlying medical problems that caused vascular disease, and now the pain they're feeling is not from any structure per se, but from the tissues not having enough blood and oxygen. It could be a biomechanical thing. It could be where their pressure is when they're stationary. Where is that pressure going? Is it going right underneath the fifth metatarsal, and that causes pain? Do they have a stress fracture, which could cause these types of symptoms? And so that one's a tough one.
Yeah. All right. Well, another viewer says they had a bone spur on their right foot taken off a few months ago. Healed okay, but now the top of the foot is sore, and now the two toes have turned into hammer toes. Wondering what can be done for the toes, and why is the top of the foot on fire after a heel spur surgery?
That's an interesting question. I mean, we would want to know what surgery was performed, first of all, whether that was on the bottom of the heel to remove a spur, or whether that was on the back with the Achilles tendon. I think that would help a lot, kind of narrow down possibly why they're having these issues. If the surgery was done on the bottom of the foot, there are a lot of nerves and structures that run in that area, and I'd be curious if one of those was either damaged, or if some of that post-operative swelling could be causing issues with those nerves that would be causing a hammer toe. I don't know what you think about the pain on the top of the foot.
Yeah, that one's tricky too, but like if there's a lot of structures that attach on the heel that go out to our toes, and if we damage those, taking that heel spur off, we can definitely develop some hammer toes. And then develop hammer toes, is our gait changing? Are we using our foot in a different manner than we're used to? And now we're getting that referred pain. Is it a nerve problem? Yeah, that's another one that needs a good physical exam to really dive deep into that.
All right. Well, another viewer says they have a lump on their foot. It doesn't hurt. Should I go in and see someone even if it doesn't hurt? And what could it be?
I'd say it's probably typically lipomas. We see a lot of lumps on our soft tissue masses on feet that are just benign collection of fat. They're usually not symptomatic. They're not painful. They're usually not in areas that are weight bearing, like under joints or anything. They're usually on the sides or the top. Ganglion cysts, those can be more painful. They're fluid filled lumps, usually along tendons or joints, but sometimes those can be symptomatic. So if it's not symptomatic, doesn't seem to be growing. If it's not changing, it's not symptomatic, you can monitor it. But if it's something that's new, it seems to be changing, then you should probably have it checked out.
Yeah, I had a very wise attending one time told me, good things come and go, bad things come and grow.
Yes.
So if it's growing, we need to get that looked into. So another viewer said their son was diagnosed with Seaver's disease. Can the doctors talk about this and what treatments can be done for it?
Yeah, so Seaver's disease, or calcaneal apophysitis, is essentially where there's a growth plate in the back of the heel. And when kids are growing, that growth plate can get irritated and then painful. We typically see it in kids ranging from anywhere 8 to 12 years old. And that pain is typically brought on by activity. So running, jumping, sports, things like that. Our typical treatments involve really making sure the calf is stretched out really well, because that can alleviate some of that tension that's on that growth plate of the heel. Sometimes we'll use non-steroidal anti-inflammatories as well as rest, icing, and then another important thing we'll use is heel lifts. So that heel lift serves a couple functions. One is it can provide a nice cushioned surface for the heel so that there's not irritation there. And it also increases or brings up the heel a little bit, providing a heel lift, which then reduces tension from the Achilles tendon too.
All right.
It's good to know that it's something that they have to grow out of.
Yes. Yep.
And so it'll always be, once they develop it, it can always kind of persist until that growth plate closes at skeletal maturity. So it could be a number of years of dealing with it.
All right. Well, in our last 2 minutes, a viewer wants to know, how important is it to wear good shoes? And does it matter later in life if you didn't wear the correct footwear when you were younger?
Yeah, like we have kind of differing opinions on this. I like to say wear the shoes that are comfortable if you don't have any foot problems. The people that do have foot problems, then yeah, wearing the correct type of gear for your type of problem is appropriate, but you know, they used to say high heels cause a lot of bunions and Achilles tendon problems just from the position of your feet constantly.
I think if you're having foot issues or foot pain, looking at your shoes is definitely a really good place to start. A very simple test you can always do to make sure your shoe has enough structure and support is just try to fold that shoe in half lengthwise, and if it just completely collapses, then you might want to look for something with a little more structure that can support that midfoot and rear foot.
I've got a couple ballet flats I need to get rid of.
Yeah. But again, like
I say, like
if it doesn't hurt,
don't hurt, and you enjoy them, wear them.
Yep.
Wear them while you can.
Yeah, absolutely.
All right. Well, this has been a very productive evening. Lots of very good questions. Who knew that such a small area of the body could have so many things for us to talk about?
Yes.
So, all right. Well, I really appreciate everything you guys did tonight, and thank you for answering over 30 questions. So, all right.
Thank you.
Well, our winner tonight is Lindsay. A book will be sent to you shortly. We'll be back after this.
Hello, my name is Dr. Ken Bartholomew, and I serve on the Healing Words Foundation Board, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Feeling overwhelmed by the amount of health information lately? Unsure of which sources to rely on? Visit the Prairie Doc YouTube channel today to catch up on all past episodes of On Call with the Prairie Doc. And don't forget to join us most Thursdays on SDPB, YouTube, or stream our episodes live on the Prairie Doc Facebook page.
Well, as we finish up this evening's discussion, I want to thank Dr. Jones and Dr. Prusa for sharing their expertise with our viewers. And thank you to all of our viewers for tuning in tonight. We appreciate your continued viewership and support of our mission of providing science-based health education. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight, or if it didn't align with our topic, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on SDPB Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio wherever podcasts can be found. Thank you for joining us on another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
Learning about medicine in Ghana offers valuable insights into the diverse approaches to healthcare around the world. Global Perspective, exploring medicine in Ghana, next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,